Good morning, good afternoon, and good evening, and welcome to the Challenge Initiative for Healthy Cities, TCIHC's first webinar in its webinar series on learnings and impact from the introduction and scale-up of proven family planning and adolescent and youth reproductive health solutions. TCI envisions a world where young people are empowered to live an optimal reproductive life by rapidly and sustainably scaling up high-impact approaches using a business unusual approach. Today, we will introduce you to one of the proven solutions that we have worked with local government to implement that is effective in not only reaching youth, but also increasing their contraceptive uptake. That is the urban ASHA approach to improve contraceptive use among young first-time parents. Before we get started, I'd like to first give you some background related to TCIHC's footprint. TCIHC provides coaching support to local governments in Uttar Pradesh, Madhya Pradesh, and Odisha, working with 31 cities across the 3 states to implement high-impact approaches related to family planning and adolescent and youth reproductive health. Of the 31 cities, 5 are AYSRH intensive sites, where TCIHC provides additional focus and resource to specific AYSRH proven approaches. Given the success of these approaches, TCIHC is intentionally integrating AYSRH across its other sites through whole site orientation and provider training. For today's webinar, I'd like to introduce you to our esteemed TCIHC colleagues based at PSI India. You'll be hearing from Devika Varghese, TCIHC's Associate Director for Adolescent and Youth and Sexual Reproductive Health. She provides strategic direction for the scale-up of AYSRH approaches in Uttar Pradesh. You could read more about her bio here. Emily Das, the Associate Director leading monitoring and evaluation for TCIHC in India. Manish Sexton, Senior Manager of Advocacy, who plays a pivotal role in demand aggregation through ASHAs in the private sector, advancing training for urban providers and facilitating government ownership through city consultation workshops. Ipsha Singh, Manager AYSRH TCIHC, who plays a key role in the scale-up of AYSRH strategies such as identifying and prioritizing first-time parents and facilitating adolescent health days. I'd like to welcome today's presenters. And before we jump in, we'd like to give you some background in terms of the logistics for today's webinar. So our presenters are going to share with you the key guidance and implementation steps, along with tips as to how to implement the urban ASHA approach to really attract and reach young first-time parents. They're going to share with you some key considerations for adapting the approach to your specific settings and how you might go about scaling the approach. And then we offer an opportunity for question and answer. So we expect that the presenters will speak for about 35 to 40 minutes, and then we will turn it over to the Q&A. So I had asked you this morning to introduce yourselves via the chat. We're asking for, during the Q&A session, or anytime during the presentation really, please feel free to use the Q&A icon at the top of your screen, and that will just help us organize the questions and answers as efficiently as we can. So you can ask questions to the speakers along with the TCIHC Chief of Party, Mukesh Sharma, will be available to answer as many of the questions as you have as possible at the end of this presentation. Now I'd like to turn it over to Devika to introduce and welcome everybody.
Thank you, Lisa. Greetings, everybody. Good morning, good afternoon, and good evening to you all. I'm Devika Varghese, and I lead the AYSRH program activities for TCIHC project in India. And I want to welcome everyone once again to this webinar. It's extremely great to be here. As we weather these trying circumstances together, the TCIHC India team wishes you and your family good health and safety. And that next slide, please, Lisa. Before we jump into the program activities, I'd like to introduce you to the character of today, first-time parent. First-time parent, a very precious phase in our lives, also brings with it unique challenges, and more so for young mothers who are poor and living in urban slum settlements. Immersed in childcare and household chores, they're often socially isolated. The National Family Health Survey India 2015-16 informs us that the lowest contraceptive prevalence rate is amongst this group. What are the reasons that contribute to low use of contraceptives? First and foremost, this most vulnerable cohort is largely deprioritized by the family planning value chain. Studies conducted in India and across the world point to low efficacy among this group to negotiate contraceptive choices and decisions with their husband and family members. Lack of agency, coupled with low correct knowledge, contribute to high rates of repeat childbirth. Despite the need for strengthening both facility-based services and community-based engagements for FTPs, very few programmatic activities intentionally address the contraceptive needs of this vulnerable group. Next slide, please, Lisa. We now take you through the key implementation steps, which are 5 in number. Together with my colleagues, we will give you an experience of each of them. The most important of them all is making first-time parents your headline. Market is failing for the young first-time parent is the advocacy headline the program developed. May I draw your attention to the graph on the slide? With almost 22% unmet need in this cohort, we definitely were failing this vulnerable group. The project amplified how health system must focus more and prioritize this group at meetings both at the national and state level. Data from population level studies, HMIS, and project health information systems were triangulated to advocate for attention to this group at state level family planning monitoring meetings and with local city health governance teams. Make FTP your priority was the project's advocacy agenda both at state, national, and city level. Next slide, please. The second implementation step is to identify the key influencer. The family planning value chain encompasses many influencers. It is important that we choose the most critical of them all. Demand, supply, and enabling environment are the 3 key pillars of TCIHC program. We did find influencers in each of the 3. On the demand side, the frontline health worker, ASHA. On the supply side, the medical doctor. And on the enabling environment, the chief medical officer, the power center in the city health governance structure. We understand the challenges faced by young mothers. To address them, it was important to choose an influencer who can support her with correct information on family planning methods and stand by her to make that decision on a method choice. Most often, support her to fight those battles, negotiate with her husband or the extended family. And therefore, the ASHA was her obvious choice. To improve demand, it was important that the program brings about a behavior change in ASHA. The change the program envisioned was saturate 100% of first-time parents in the community with information on family planning methods and refer them to the facility, which essentially means that the ASHA meets every single parent in the community and provides correct information on family planning methods and refers them to facility where FP methods were available. Today, our story is woven around the ASHA and her role in reaching young first-time parents for healthy spacing of second and subsequent births. Next slide, please. Accredited Social Health Activists, ASHA, are voluntary health workers chosen from the community and trained by health systems to offer a range of services, including family planning counseling and information. She serves a population of approximately 2,000. Population estimates determine that amongst a population of 2,000, there are about 15 to 20 young first-time parents. A large part of her remuneration is a variable pay and linked to her performance on various services. Next slide, please. If we have to work on changing behavior of our influencer towards making family planning a priority and making first-time parents visible, it was important that we understand what motivates an influencer and what are the barriers towards a behavior change. So what motivates an ASHA? ASHA is motivated by community recognition and health system rewards. Timely payment of her incentive is an important motivator for an ASHA. And what are her barriers? Often entrench the beliefs and norms of the community. Her supervisor priorities mostly include immunization, antenatal care, and deliveries. Interestingly, conversation between ASHA and her supervisor are in the order of priority of children immunized, antenatal checkup, deliveries, and family planning activities are often deprioritized. So to summarize, our second key implementation step was to identify the influencer and understand what motivates them. I now invite Ipsha, who is our program manager for AYSRH, to introduce us to the third implementation step. Over to you, Ipsha.
Thank you, Devika. The third and critical step is to coach your influencer towards the desired behavior change. The behavior we are referring to here is saturation of 100% of FTPs in the community with the information on family planning and information on facilities where family planning services are offered. To saturate, ASHA needs information on the denominator like how many first-time parents are there in the community she serves. The colored boxes that we are seeing on the slide is a representation of the different kinds of data and ASHA gathers, such as listing of families in the community, a list of pregnant women, list of children due for immunization, and number of couples adopting permanent methods. Based on group discussion with ASHA in monthly meetings, we come to an understanding that less than 10% of ASHAs know how to use to this data for data decision making, like using this data for make a daily work plan and route map, making a list of priority clients for family planning counseling. The project's coaching model for ASHA focused on building capabilities in ASHA to reorganize data that is already available from her multiple registers into a format that helps her prioritize the vulnerable cohort for family planning, the first-time parents. Next slide, please. Towards making data useful for ASHA and to make FTP data visible, the program coached ASHAs on a sales funnel inspired model. The first step is ASHA listed information about families in her community in the Urban Health Index Register. Second step is the program coached ASHAs to color code first-time parents from the UHIR register, marker for users and non-users. Third step is prioritize home visits to non-users in daily work plan, route map, and segment users for follow-up visits and reminder service. Next slide, please. The coaching followed a tactic. In consultation with their supervisors, ASHA were organized into small groups, such as a mix of performers, early adopters, ASHAs with a growth mindset, and naysayers. The coaching sessions were organized into 5 sessions, and the initial 3 sessions, the group met once every week, and the last 2 sessions, the group met once every fortnight. The first 3 sessions were dedicated to reorganizing data and developing work plan and route plans. Behavior of early adopters created a normative pressures in the group towards reorganizing data and prioritizing FTP visits. The last 2 sessions was about meeting to discuss progress in the counseling sessions, challenges, and learnings from success stories. Slowly, the session was integrated into the monthly review meetings of the ASHA and her supervisor. Thank you. Now, the fourth implementation step will be detailed by Dr. Emily Das, Associate Director, Research and Emily, TCIHC India. Over to you, Dr. Emily, and thank you again.
Okay, thank you. Thank you so much, Ipsa. So now I'm going to describe the fourth step, which is how closely we monitor the performance of this influencer, ASHA. As we know, the country HMIS in India does not actually disaggregate users of family planning by age and parity. Therefore, TCIHC program in the very beginning designed a project management information system that we call it PMIS. This PMIS captures data, two critical data points, in fact, that supports the program decisions at every level. One, at community level, it records number of women reached with information on family planning and captures women's age and number of children born to the women, that is parity. Two, at facility level, it records the number of users of family planning by their age and parity. So the graph that we are looking at in this slide is the data that we captured at community level in PMIS. That is the percent of first-time parents reached by the program. The graph narrates that all of the women made during this peak intervention period from October 2018 to June 2019, more than 50% of the women were first-time parents. Let me also draw your attention to the peaks in the graph. These peaks are months of intense project intervention, especially for AYSRH. It is also interesting to note that there is a drop post July 2019. This is because most ASHAs had saturated more than 90% of the first-time parents in their community with information on family planning. Next slide, please. So while the last slide that gave us a peek into the percent of first-time parents reached this slide, now this slide is actually the data that we collected from the facilities on the uptake of family planning services by young first-time parents. During the intervention period between October 18 to June 2019, what we are seeing here is 40 to 50% of the women who availed services at the UPSCs are actually the first-time parents. Actually, we'll talk more about this in the results section, where we will discuss the data from a population-based survey that we call as output tracking survey that we have conducted in September 2019, which also reports MCPR among this cohort in these 5 AYSRH cities. Now, the last and the most critical of our implementation step will be presented by Mr. Manish Saxena. Manish is our advocacy lead for both TCIHC Classic and AYSRH program. So now over to you, Manish.
So thank you, Emily. Now we will discuss the fifth of the implementation step is linking influencer performance to reward and recognition. This is the highly motivated factor for ASHAs. Reward and recognition motivate ASHA to do more in the field. Ensuring worth spacing scheme is a government incentive scheme to promote worth spacing. The scheme incentivizes ASHA for supporting women in 3 ways. First is delay first childbirth, that means ensuring a space of 2 years after marriage. Second, ensuring a space of 3 years between subsequent births. Third one is couple opt for permanent limiting method up to 2 children only. This scheme was, however, underutilized in the urban. ASHA were mostly unaware about this scheme and the required paperwork for claim. And with no claim being processed and know how in processing the particular claim was missing among the city governance team. The TCI project advocacy team played a large role in removing these roadblocks. Working closely with the government, the team developed simple, easy to understand steps for submitting claims. The steps were printed out into handouts and integrated into coaching session between ASHA and her supervisor. Additionally, the team advocated with nodal officer responsible for the claim reimbursement for a quick. And for the first time, TCIHC effort almost close to 125,000 USD ESB fund were allotted in the 5 cities. This is the first time these funds have been allowed in urban. Recognizing ASHA success through most significant change stories and featuring ASHA as a champion in the TCI University also propels the ASHA motivation. Here, I would like to read a quote from ASHA, which is also mentioned on the screen. Learning how to properly fill my diary has helped me to maintain client records in a systematic manner, and now I can easily and quickly extract specific information like first-time parent and adolescent couple detail for the family planning. So thank you. I really enjoyed presenting our work in this webinar today. Now over to you, Devka.
Thank you, Manish. That summarizes the 5 of our key implementation steps. Make FTP your headline, recognize your influencer, coach your influencer, link your influencer to reward and recognition, and monitor the performance of your influencer. Next step, next slide, please. Yeah, this is good, Lisa. So to complete our implementation steps and to summarize, key implementation considerations for projects planning to adapt it in different geographies, we have a few pointers. The health system value chain encompasses many influences. It is important we choose wisely. This is a point that we're reiterating again because this is a very, very important and critical point. We need to define the behavior that we are seeking from the influencer. We need to leverage existing health systems, policies, and schemes to build the desired behavior. And these policies and schemes must be ingrained into the government systems and should not be a parallel system that the program designs or develops. It is important that we reward and recognize our ASHAs, our frontline health workers. Here are a few stories on ASHA posted in the TCI website. When our field team show these to the ASHA, their faces light up with smile and pride. Next slide, please. As ASHAs work passionately, as their performance improves, and as demand improves, it's important that service delivery platforms must respond to the increasing demand. In the AYSRH cities, the chief medical officers ensure supply of commodities, including injectable contraceptive in the UPHC. This is particularly interesting and important because in India, injectable contraceptive was only added to the contraceptive basket in late 2016. With Government of India planning a cascade approach to the introduction of injectable, introduction to urban primary health centers was last in the priority. The program's continued advocacy efforts and the bulging demand for choice nudged the city governments to fast-track the process of getting injectable to UPHC. This is a big win for TCIHC India because if we had followed the usual pattern, probably injectable contraceptive would not have been in the basket in last year, and that would have really created a choice constraint for these young mothers who are wanting to adopt a spacing method. And that summarizes most of our activities and our implementation considerations, Lisa.
Thank you so much, TCI team and presenters. Before we move on to the results, there are 2 questions that bubbled up from listening to the implementation experience. First, I'd like to ask, how do you attract young first-time mothers in particular? So you noted the importance of the influencer, but what seemed to actually really resonate and attract the first-time parents?
So what we noticed was is young mothers actually have very, very low networks, or maybe even no network at all. Because we've already seen that they are socially very isolated, and so their networks are very small or probably no networks at all. And their knowledge on facilities to avail family planning services is also very, very low. And this is where the city governments responded to the efforts of ASHA by organizing a special fixed day service for only first-time parents. It was like a day reserved for them in the UPHC. It was a fixed day service for spacing method, but specially reserved for the first-time parents. You may also want to notice in the slides here, we have some pictures that we have put up. You may notice that in these images, the UPSCs are decorated with balloons. There are some UPSCs even set up corners with toys to keep the children engaged. This was actually to break that myth of a very serious, image. That was just to make it a little interesting. And in the community counseling sessions, ASHAs most often inform the young mothers of the special FTS day. And to mothers who confirm their visit, ASHAs even allocated a time range, a sort of an appointment. This was a large relief for them because it significantly reduced their waiting time, which was, I think, one of the major attractions for them to actually come into the facility.
Thank you for those additional insights and details. I think that's very helpful to understand kind of the warmness and welcoming environment of the UPHC and how the facility was really accommodating the needs of the client. In terms of implementation, we were also wondering, what challenges have you experienced, and what do you think these challenges, how do these challenges relate to kind of adaptability of this approach?
So this is the continued challenge being the provider biases on offering certain methods, particularly injectable, to this young cohort of women. And that is a big challenge that we continue to work on. And we know that is going to take time, but we are also sure that demand from young parents on young mothers on spacing methods will probably help us move this barrier also. And additionally, I will also like Manish to talk a little bit more about the challenges that we faced with the ESB scheme.
Yeah, sure, Devika. So unlocking the ESB scheme for urban ASHA and its timely reimbursement is a big challenge. Paperwork for ESB reimbursement is a complicated process. Knowledge gap existing in both ASHA as well as in the officers, ASHA on how to submit the claim, and officer having the less knowledge about the mechanism to process it. This was leading to delay from the both sides. Officer who had to verify the claim and process the payment were unsure of the policy and guidelines. So to bridge these gaps, project supported both ASHA and the local governments by the advocating for inclusion of ESB scheme in the agenda of monthly review meeting of ASHA, recognizing good performing ASHA at UPSC level so that other ASHA can also be motivated, verification by supervisor of ASHA on the work done by ASHA toward ESB scheme, and nudging chief medical officer to monitor implementation of the scheme, and support local government to develop IC material so that ASHA can understand step for submitting claim better. Orientation of ASHA towards the record keeping and implementation of ESB scheme. So that's
Yeah, so basically what happened was, on one side, the ASHAs were struggling with what were the paperworks and how do I submit the claim. And on the other end, the departments were also struggling with this new scheme that's beginning to unlock in the urban. And I think that is the work that the project did, was just to bridge this gap between both the parties and get this move, and just to oil this mechanism and work so that it works effectively and efficiently.
Thank you both, Devika and Manish. We have a number of questions that are starting to come in the chat. I'll continue to collect those and we can address those maybe after we move on to results, if that's okay with everybody.
Yes, great.
Okay.
So can we have the next slide, please, Lisa? So what are our results? So we did see indications through the project management system, but the project didn't want to stop with that. And to understand more about the MCPR among this young cohort, the program conducted a population level survey in September 2019, almost a year of program intervention. And let's see what these studies tell us and what we have learned from this. May we have the next slide, please? Now, the study, the Output Tracking Survey, was conducted in 5 AYS-RH cities and a sample size of 1454. It is interesting to look at the first bar, which actually tells us that almost 67% of women 15 to 24 years with one child reported program exposure, which means they have either been counseled by an ASHA or been a part of a group meeting on family planning choices, and or visited one of the 3 family planning service delivery platforms. In India, in the urban slums, with TCIHC support, we have actually activated 3 service delivery platforms for family planning, one being the Urban Primary Health Center, which is the facility, the 2 outreach camps, which is at the community level, and 3 urban health and nutrition days, again at the community level. So 67% of women have reported that they have been exposed to one or more of these program intervention, which we think is very, very significant. Now, to know more about the CPR amongst this cohort, I would request Dr. Emily to talk more about it, which we'll have in the subsequent slides. So, Emily, may we have you to talk more about the MCPR in this group, please?
Yeah, thanks, Devika. So now, as we are now seeing a slide, I mean, this slide actually tells us the results from this population level survey conducted in 5 AY cities in September 19. You will see two charts in this slide. In the left-hand side, you will see a chart with MCPR among women 15 to 24 years in 2 time periods, September 2018 and September 2019. And in the right side, you will see a graph with MCPR among young first-time parents. So the results from this is indicating that we are seeing exactly a 17% increase in MCPR among first-time parents in the age group of 15 to 24 years, because this cohort is actually interviewed for 15 to 24 years only. And we are seeing a 9% increase among all women 15 to 24 years. So now this unprecedented increase in MCPR and the significant exposure that Devika just mentioned to program activities among this cohort all point actually role played by the ASHAs in reaching FP information and services to these young mothers. In fact, we have calculated this MCPR using calendar method. For those who are interested in understanding the use of calendar method in calculating MCPR, you may please kindly write to us or we can discuss it more. Now, next slide, please, Lisa. Yeah, so now this slide tells us about method mix among first-time parents. You will see 2 pie diagrams in this slide. In the left side, again, you will see the method mix in September 18. And in the right side, you will see method mix in September 2009 among the first-time parents. So what we're seeing here, that along with the increase in MCPR that we saw in the last slide, we are seeing women who also got the method they wanted as a family planning choice in the facility. So both long-acting methods like IUCD and short-acting methods like injectable, condom, pills also showing an increase. So here I would like to also draw your attention to see the drop, that is we are seeing exactly a drop in non-users from 68% in September 18 to 45% in September 2019. So these are some of the broad findings from our output tracking survey that we have conducted in 5 cities. So now let's hear more from Devika, just what exactly we have learned from this. Thank you. Thank you all.
Thank you, Emily. So we encourage you to write to us. You can speak to us. You can call us if you want to know more about these results. We are as excited to speak to you more about it. And now to go back to what we have learned. Now, this last 12 to 14 months has been one of the most exciting period for all of us. And we've learned so many things, both quantitative, qualitative behaviors. And it has been really, really encouraging and a beautiful experience. I'd like to speak a little bit about our most important learning, which is the diffusion effect. As a result of learning about AYSRH cities, many non-AYSRH, which is the TCI classic cities, began to informally add on AYSRH activities. These cities also began to exhibit increased results in reaching women 15 to 24 years and referring them to facilities. While TCIHC AYSRH cities still reached more young women, which is 50.3% than the TCI family planning only cities, which is 42%, the fact that there is no large gap between the 2 different city groups speaks to the scalability of the AYSRH approaches. Next slide, please. And these are some of the key learnings, key takeaways that we have, where we said that to influence a growth mindset, to influence a mindset change, we need to demonstrate. Show me and I will remember is something that we have learned. So it's important that we demonstrate. It's important to show the results. Quick wins are always encouraging and important. Mentoring and coaching requires human interfaces. Influencing mindset change towards growth is the most difficult of all. And it's important that we place great mentors and great coaches who show and lead the way. FP interventions strengthen overall quality and service delivery in facilities. Prioritizing first-time parents is key as they are the highest in need for family planning methods. Creating coaches within the system is important for sustainability. The program could have always chosen to have a parallel coaching system, a parallel IPC, but that's not what TCIHC stands for. We believe in creating and enabling those coaches within the system. Estimating denominator family planning non-users is key for sustained scale-up. I need to know my denominator. I need to know how many people I need to work with. And I think that understanding our universe is important and critical. It is now celebration time in TCI India Hub. We celebrate ASHA's success and every young mother's success on adopting a family planning method of her choice. The work we showcase today is the hard work and passion of our 1,500 ASHAs and about 1,200 UPHC staff across 5 ASRH intervention cities under the stellar leadership of their chief medical officers. And also I would like to congratulate all 5 of the TCIHC city managers of these 5 cities, Akbar, Keval, Kriti, Mange, and Vivek. Thank you.
Thank you so much, Devika and team. And that's great closing remarks. It's very obvious from your presentation, the importance of key influencers at a variety of levels and knowing how to interact and work well with them is key. So a huge kudos to you all and all those that you've mentioned in this presentation. Now we'd like to turn to a few questions that we've received. Given that we just closed on talking about results, I'd like to ask a question in terms of related to the OTS. It looks like there, or even your PMIS data, is there any information on continuity or continuity of contraceptives, especially given the leaning towards some short-term methods?
Emily, will you like to take the question for OTS?
Yeah, Devika, yes. So as I told in the presentation that, we have collected this data using a calendar method for collecting contraceptive behavior among women for last 45 months. I mean, the best purpose of using calendar method, this method is actually universally employed in all the DHS, and the major purpose is actually to calculate discontinuation rate among the cohort interviewed. So continuity for this last 45 months, I mean, once the method started, we can jolly well measure that. We have actually calculated that for each method, but we can discuss it more. Yes, this data set actually allows us to measure that.
Wonderful. Thank you for that additional information. It looks like the other questions we have relate a lot to the implementation process. So first, I'd like to give everybody kudos. We've heard from a number of the attendees, amazing presentation from the TCIHC team, always learning something new. Thank you for this very interesting and practical presentation. And they wanted to know, given, I'm curious about how ASHA supervisors, so A&Ms, responded to TCIHC's efforts. I imagine particularly early on that this impacted ASHA's other work significantly given the implementation steps. So what did TCIHC do to address or ease any of the supervisors' concerns given that the incentives are directed to the ASHAs?
Yeah, so to answer this, Lisa, we'd like everybody to step a little back. So as we all know that there have been a number of trainings that the ASHA and her supervisor undergoes on family planning as a content on the technical part of it. But however, skills like how do I organize my time? How do I plan my priorities? How do I make my daily work plan? How to look at my data and make decisions? This was largely the gap that we were seeing. And with respect to the A&M and ASHA's communication, it was important that we start planting family planning into these conversations. And if we wanted to plant family planning into these conversations, there needs to be some kind of a data on which both the A&M and the ASHA can talk. With respect to immunization, there's always a due list. With respect to deliveries, there's always a due list. With respect to antenatal care, there's always a due list. And conversation between an ASHA and A&M always are woven around this due list. But for family planning, this is missing. And that's exactly what the program's focus is, to bring a list of women who needed the service. And when that list or that denominator is aggregated, it becomes easy for a supervisor to supervise a supervisee and it also becomes easy for the ASHA to start reporting her work. So it is in no way eating up any part of the ASHA's daily plan. It is in fact propelling both the ASHA and the ANM to success levels. So the program, what we did was just initiate those conversations by using a scientific method to determining these cohorts. That's what we did.
Excellent. Thank you so much for that explanation. Again, another question that came in, given that a number of our attendees also represent some of the other hubs around the world. One of the questions is, what would you recommend to some of the other teams related to how to motivate, incentivize community health workers that are possibly not paid? Or in other words, you know, if ASHAs did not receive this financial reimbursement, how would your approach differ?
Okay, so all right, let me attempt that question. So what we have seen with respect to, with respect to the influencer that we were working with, we have seen some other kind of models also in India where there is a, okay, let me come to this first. So with respect to these ASHAs, with our frontline health workers, a number of studies have always said that both rewards in terms of incentives and also being recognized by the health system and being recognized by the communities also play a large part, play a large role. And most often we have seen that while it's easier said than done to recognize, and we see that even that part of it is not usually completed to perfection with respect to, you know, giving her awards or recognizing her in the community or being recognized in the health. So that is one part that TCI did also with respect to the incentives that is already available. Now, in certain cases, we have seen in India also where there is work with the private sector, where there is an entrepreneur model also, where there are frontline health workers, where they are selling commodities and they earn some kind of a margin or an incentive. So there is that kind of a entrepreneur model also that we have seen with frontline health workers. Some of the projects are trying that model out too. So largely I would say that there has to be some kind of an incentivization, which is either a variable pay or something that there is an entrepreneurship that is built into this. Or secondly, it's important definitely to recognize them through various platforms that is available. This is what I would say. I also invite Mukesh if he has more points to add to this.
Thanks, Devika, and I think you made the right points. Just wanted to add one more point there, that Lisa and everyone, I mean, if you see the landscape of health services in the country, we know that there is huge resources available with the government, and they have very good infrastructure. Good in the sense, at least infrastructure is present at everywhere, rural, urban. But the utilization of services by most vulnerable section or poor population was very, very low. So the idea of implanting these ASHAs by government was, to play a role of bridge between communities and service delivery, and that they the same role they are playing. What we believe that this is not going to be the lifetime arrangement. So maybe 8 years, 10 years, 15 years, when these things becomes a norm for the community, immunization is a norm for community, family planning is a norm from the community, then slowly they will withdraw this model. But yes, currently they require a person who can bridge this gap and link communities with the facilities and services.
Thank you both. That's really helpful. And your words exactly match up with one of the questions that also came in terms of, one of the barriers is often community norms related to family planning uptake. So how did the ASHAs manage this?
Yeah, so so in India, if you look at it, so it is important that women exhibit their fertility, have children soon. So these norms do exist in the community, and even with the providers, there are biases in providing certain methods to young mothers. So the first and foremost for us was to exhibit to the ASHA that there is a cohort like this, and they have too many other problems with having a close birth spacing. So we actually have a tool called as the 30-hour magic, which is actually a process that we implement in the field. The 30-hour magic is a demonstration tool where the TCIHC team go into the field, and in 30 hours, which is 3 days, 10 hours in each day, we actually show them a snapshot of what demand exists in the field, what kind of preparations that is needed to meet this demand. And we take a small group of ASHA with us when we do this demonstration. So when we were demonstrating this on the field, when we were meeting young couples, when we were meeting young mothers, and when the ASHA actually listened to the tales that they had to say, that was I would say a kind of a life-changing experience for many ASHAs. They in fact told us that we didn't even realize that young mothers would require contraception. We always thought that they need to have another child soon. So what was the need? So sometimes, like what we said, what our learning was that in terms of demonstration, I think was one of the tools that we used to bring about this behavior change. No amount of classroom training, no amount of case studies, no amount of role play is going to help this. What is helping us was to actually take them with us to the field and make them listen to the stories of the young mothers who are in need of family planning services.
Great, thank you, Devika. Mukesh, would you also like to add to that?
Yeah, just to add that, Devika, you rightly said, just to add, Lisa, that, especially in this newly married couple and first-time parents, we were a bit lucky in terms of first-time parents, because the norm and the community pressure especially is very high for the newly married couple. And the proportion of newly married couple in the population is 8% in country as of now, as per in FHS. So what we believe that for the first time parents, we worked and we demonstrated, as Devika mentioned, that really worked, and it changed the mindset of ASHA as well as communities as well as providers. And the work which we are going to do with unmarried boys and girls, that is going to reflect more in the coming future, when they will be the married couple and they have to face some norms that is going to impact there. But yes, for the first time parents, yeah, we did well.
Oh, sorry, I think I muted myself. Okay, I think that also relates to this question around what is the plan for sustainability of the prioritization of first-time parents in the 5 AYSRH cities?
Yeah, so the project has in fact graduated out of one of the processes that we had, which was the coaching approach, which is the LOVE model. We can talk more about it when we have time and people are interested can write back to us. So we have graduated from that model into a prioritization tool called as a 2x2 matrix. Now, the 2x2 matrix is a tool that helps ASHAs to segregate the users and non-users in her communities that she serves by age and by use. And now, what we are doing is so it's basically helping ASHA to use her data for making decisions such as which is the group that I need to prioritize, which is the group in my community which has the lowest MCPR rate. Is there a method that is showing a large bias to? Can I talk to my clients more about more reliable methods? So this is a matrix which is actually it has 2 axes. On one axis we plot women's age and the other axis is the use. So we are able to disaggregate women by different age and their use. Now, when we are trying to put this tool into, trying to coach the ASHA to use this tool, and we are trying to integrate this tool into the ASHA and her supervisor, ANM's, planning and monitoring meeting, we are sure that what happens very, very naturally, that data gets into this tool. The ASHA and the ANM will see the number of young mothers who are users, non-users, and that will create a very natural flow of conversation, a natural flow of planning, and a natural flow of monitoring to saturate these cohorts and reach family planning services to them. So this is the way we are trying to integrate this into their usual, coaching and mentoring plans.
Perfect. And
So,
Mukesh, you had something you would like to add?
yeah, thanks, Devika. And just to add, thanks to bring this 2x2 matrix. So, Lisa, what we learned during this AI implementation in 5 cities, it was not an easy task to work with ASHAs and their UHIR register to get the list extracted from that, section 8 of UHIR register, where they put all the family planning information. You have to go with each and every column, then you are putting who is the first time parent, who is having more kids, you are preparing a list, then preparing another list for, so all these things we did because it was required, and prioritization needed to be set. With the 2x2 matrix, if data is visible in a very simple way at the community level, that is going to work for sure. What we learned, 2x2 matrix is very clearly saying ASHA that okay, in 15 to 29 years of age, this much of non-users you are having, or users you are having for the resupply and follow-up, and almost 100% of the first time parents will be covered by covering these 15 to 29 years of age. The best part is government has adopted this, and now all 31 cities, including all 3 states, they are using this 2x2 matrix for the prioritization. So in bridge year, this is going to be, we will provide more coaching mentoring so that this use of data can be sustained with the government. And it's very easy, so we believe that this will be sustained.
Thank you very much for those additional words. And for those who are in particular interested to learn more about the 2x2 matrix, the TCIHC team has documented this as one of their most significant change stories in the last quarter. So that will be going up on TCI blog probably in the coming weeks. So those who are interested in this webinar and interested in more details, specifically around urban ASHAs and reaching FTPs, we can make sure to share with you those links as well. And then I have a few additional questions that have come in related specifically to data. So the first question is, going back to the slide on program exposure, there was the question, what % of FTPs became users of modern methods among those 60% or 67% that were exposed?
Yeah, let me just answer this question, Lisa. This is, if we look at the entire data that by exposure status, the use of modern contraceptive methods, specifically the use of reversible methods for this cohort of women is actually high. It's actually half of the FTPs, those who are exposed to any of the intervention activities are actually using a modern methods. And to be very honest, the sample size was not actually measured that way to look at this, but yes, we can look at the distributions that gives an idea. But wanted to say that those who are exposed are actually, chance of using methods are very high. So that's what we are saying.
Great. And then one of the follow-ups I think is also, so there's 2 more. One is, what attracts couples to use LARCs? Well, what attracts the first-time parents to use LARCs compared to using condoms?
Devika, would you like to answer this? Or?
The OTS survey that we did cannot give this answer. We don't have an answer from the OTS to give this. And we also don't have a qualitative survey that we did that can answer this question. Probably I probably don't have an answer to this as to, what I might be saying might be my perception. So
totally understand. Thank you.
Can I?
Yeah, go ahead.
Can I say something? Okay. So I'm just linking this with the.
Wants to say something.
I just wanted to link this with the mentoring and coaching we did with the ASHAs when we had the grassroots level coaches. So and the priority was helping ASHAs to have informed choice counseling in the communities. So that was the prime in all the trainings happened for the ASHAs, and they were provided with the materials and IC materials to counsel the women with all actual methods on a chart so that people can touch and feel. So having said that, if you have informed choice counseling, then you can choose a method. If you see the data in any survey data in India, the choices were always a constraint. And people are struggling at how, to help people with the more method choices. So if you are going with to a couple with a counseling with all the methods including pills, condoms and everything, it's up to them that what they are choosing. We followed the same thing, and I believe that in the bridge year and beyond we are going to also work and help ASHAs through ANMs that counseling more on the informed choice and counseling more on the more reliable methods. But yeah, giving the option of all the methods, help them to choose a method, and because they are first time parents, mostly they are choosing condom. It's okay with us as of now.
Well, and just to also add, oh, am I muted? No, I'm not. Okay, I'm sorry, now I'm not muted. And please correct me if I'm wrong, Mukesh and Devika, but prior to TCIHC's intervention, the UPHCs weren't really offering many of the other methods such as injectables and IUCDs. So not only the informed choice counseling and coaching that's being done with ASHAs has made a difference, but the fact that the UPHCs are now actually equipped to provide those methods when they weren't before.
That's right. That's right. Yeah.
Okay, great. And then I think, Mukesh, when you spoke, you mentioned how, I think you said 8% of married couples are newlyweds. Is that correct? So the question was, do we know what percent of those newlyweds are actually first-time parents? Is there any kind of data around that?
So when I said newlywed, it means zero parity.
Okay.
So yeah.
Okay, I think that covers it then. Great. So right now it looks like we've answered all the questions that had come in. We are seeing a thank you TCIHC for an excellent webinar, very informative and clear. I'm looking forward to scaling up to more locations. Great job team from Kojo and others. So at this point in time, I think that, as I mentioned in the chat, this webinar is being audio recorded. We'll make sure to upload the recording and the PowerPoint slides to TCI University. We'll also circulate them after the webinar. And this is just a reminder that this was our first webinar in a series. So next Wednesday at the same time on May 13th, you'll be hearing from TCIHC team about mindset shifts, specific male engagement strategy to increase male participation in family planning. And with the webinar slides, we will add the presenters' email addresses in case you have follow-up questions that you'd like to direct specifically to them. So at this time, I'd like to say thank you very much, TCIHC team. That was extremely informative and crisp, and it was very helpful to see how you organize the implementation steps and the context-specific elements of the Indian health system, but also how that can be taken into consideration elsewhere, specifically related to knowing your influencers and this idea of, there are different ways to recognize your influencers at multiple levels and the importance of working the demand and service side simultaneously. So thank you so much, everybody, for your time, either this morning, afternoon, or evening, wherever you're joining us from. And we look forward to you joining us again next week to learn more about the male engagement strategy. So thank you.
Thank you.
Thank you. Thank you, Liza.
Thank you,
so much.
Lisa. Bye-bye.
Thank you, everyone.
Bye-bye.
Bye.
Bye.